back to our weekly expert series, everyone. I'm with Dr. Ami Kapadia. Hopefully I'm getting her name learned. MD, AB, what's ABFM?
It's American Board of Integrative and Holistic Medicine, and then American Board of Family Medicine. I was trained in family medicine, so.
Awesome, very cool. Ami has practiced family medicine and integrative medicine since 2005. She completed her residency at the Thomas Jefferson University Hospital in Philadelphia and went on to work in various settings, including an inner city urban clinic, VA hospitals around the country, and urgent care clinics in the Portland area. She has pursued training with the Institute for Functional Medicine and the American Academy of Environmental Medicine, and she is certified by the American Board of Integrative and Holistic Medicine. She's been practicing at Kuan Yin Healing Arts Center East in Portland, Oregon since 2015. Her practice focuses on digestive disorders and autoimmune disease, and she pays particular attention to the role of chronic infections, allergic disease, and environmental exposures in illness. So first of all, welcome. Thank you for your time and coming
Good to be here.
on. Yeah, so you've got an interesting background, and now you're doing sort of this functional internal medicine. How did you make that transition?
Well, I've always been interested in integrative medicine since I was in school, and I just got lucky in Philadelphia. My first year mentor in medical school was the head of our integrative medicine center. So I just started following him around when I was a student about 20 years ago.
Cool.
And then gradually incorporated more and more as I went along.
I like your diverse background too. I think that helps you, be more informed than just like seeing the same thing kind of over and over in a sense. So
right.
So great. So we're going to talk today. Your talk is a minimalist approach to SIFO and mold illness evaluation and treatment tips. So maybe can we start with your definition of SIFO and mold illness?
Sure. So the way I like to think about SIFO, or small intestinal fungal overgrowth, I think a lot of your participants probably are familiar with SIBO. And so it's an overgrowth of fungal organisms instead of bacterial organisms in the small intestine, but otherwise has a lot of similarities to SIBO, and we can talk about that. But as far as the definition, it's basically an excessive number of fungal organisms in the small intestine. And with mold illness, as again, I think most of your audience is familiar with, it's sort of an umbrella term. Different practitioners call it different things, but I like to kind of keep it somewhat generalized because we know environmental mold can cause so many different symptoms for people, from allergy to potential colonization to mycotoxin exposure. So I kind of use it as an umbrella term for all of the different effects that environmental exposure to water damaged buildings can have on anyone.
Perfect. I'm kind of the same. So I think you did have some slides you wanted to share, right?
I did. Do you have those, Bridget?
I have them somewhere, or you can screen share too if it's easier. If you're
I don't have them like on my desktop, but if you need to, I'm sure I could figure out how to get them on the screen.
Sorry, we should have coordinated that a little.
No problem.
I'll go grab them real quick.
Okay.
We'll just chat. So you are really perhaps the first person ever talking about SIFO on the series, so it's pretty exciting. I guess maybe my first question while I look at these slides is it common, and how do we know if we have it?
Yeah, so I think it's quite common. The challenge is there's not a good non-invasive test like we have for SIBO. There are tests that I use that help get some clinical clues as to whether someone has it or not. You can't tell by symptoms alone. And we know from Dr. Rao's publications, the symptoms can overlap quite a bit with SIBO. They're very similar. So, the typical IBS symptoms like belching, bloating, diarrhea in the research studies, but we see constipation quite frequently clinically as well. So you can't differentiate based on symptoms alone. But in the published research, there was a significant number of patients with IBS who had SIFO, and some had both SIBO and SIFO. And so clinically, I do think a lot of the patients with IBS and various digestive issues may have this as a piece of their puzzle. And we can talk about some of the tests that we use to get clues. Really, the gold standard is to get an endoscopy with fluid that's collected and get that analyzed. But I don't think very many GI doctors actually do that. So for most of us that are functional medicine or integrative medicine practitioners, we do some lab testing. And so, you know, the most useful labs that I found are actually just standard labs through, oh, there we go. Standard labs through Quest or LabCorp. And we can talk more about those now, Bridget, or after we kind of go through some of the other background info, whatever works for you.
Yeah, maybe we'll save it. I know I kind of
Sounds good.
that went in a little early. So yeah, this is really helpful. I guess just following up on what you said, sounds like a lot of it goes by symptoms, and is knowing that the person had a mold exposure a pretty key, like sign?
Not necessarily. So
okay.
yeah, you know, it can be, the way I explain it to patients is mold and candida are all in the same kingdom of fungi. And so definitely if there's someone who has sort of a resistant case of SIFO or resistant symptoms in a whole host of different organ systems, we always think about potential environmental mold exposure. And so the way I like to think about it and explain it is that if our body is having this environmental exposure externally, we're going to have a hard time for our immune system to control the internal yeast, just because, again, it's in the same kingdom of fungi where we have some external immune suppression going on. And so our immune system is going to have a challenge to keep the internal yeast in check as well. So I would say I do frequently see it in patients that have environmental exposure, but not necessarily vice versa. Like I have lots of patients who have what we think is probably intestinal fungal overgrowth that don't necessarily have an environmental exposure as well.
Okay. So do you want to walk us through this slide?
Yeah, that would be great. So this is just sort of a pictorial diagram I made for myself for how I think about fungal related, yeast related disorders. And so on the left, infection is what we all are relatively familiar with in regular medicine even. So that would be things like toenail infection, which is called onychomycosis when there's a fungal infection there, or women get vaginal candidiasis, that can be an infection. And so those are types of infections that are pretty well recognized, and we have somewhat standard treatments for them that work pretty well. In the middle, we have SIFO, which is fungal overgrowth, and it's not really an infection like we talked a bit about. It's more of an overgrowth of organisms in the small intestine that are typically not found there in those concentrations. And then on the right side, we have immune-mediated or allergy or hypersensitivity. And this is not as well recognized as far as how our bodies can interact with yeasts and fungi. And, you know, certain people are predisposed genetically to have allergies. And there's likely some genetic component to patients who get a sort of hypersensitization to yeast or fungi. Of course, we know about mold allergy. You can also have a yeast allergy where you're having a more IgE type reaction to candida or yeast that lives on our mucous membranes. And we know if there's an allergic or hyperreactive immune response, that can actually affect the immune system in such a way that you're predisposed to recurrent infection. That's been shown in research. There is not research on the allergic component predisposing to SIFO, but I suspect that there's a connection there as well, just because of the way we know allergy affects inflammation on our mucous membranes, making it somewhat more prone to overgrowth and infection.
Interesting. Okay. I think I can forward your slides here. Yeah.
Okay. Okay, great. So this is a slide from a course I put together that just goes into a lot of detail about all of the different ways we want to approach SIFO. And so as you can tell from the pyramid, we always want to start with the foundations that, again, most of your participants are probably familiar with, but we sometimes forget to address. And so I just like to at least mention it. I've had patients where I assume all of the foundations have been covered, and then we do a lot of other more involved therapies and realize that we forgot to address one of them. So just kind of briefly going into them. With sleep, we know that our immune system and just in general, we can't heal if we're not getting appropriate sleep. So we always talk about sleep hygiene, and I recommend patients get blue blockers for nighttime if they're going to use any electronics, things like that. I do some basic electromagnetic field mitigation with most of my patients. And I have a free handout on my website. There's a bunch of resources if anyone's interested, but it just goes into some of the basic things I do with patients, like turning your Wi-Fi off at night, not plugging in anything close to your bed within 6 feet, keeping your phone on airplane mode, all of those basic things. And then one that we, again, often miss is addressing stress. A lot of us, it's a constant we need a constant reminder for prioritizing some sort of stress reduction techniques for ourselves, or again, our immune system can't really heal appropriately. So those are the foundations. And then as far as nutrient deficiencies and risk factors, there is research that was published many decades ago on some of the common nutrient deficiencies in patients with fungal overgrowth. And so those are also things that I check frequently with patients. Some of the biggest ones I find are B12 deficiency, zinc deficiency, and iron deficiency. Iron deficiency in particular is really interesting because it can be kind of like a Goldilocks where you don't want too little or too much. There is good research on trying to get a ferritin level above about 50. So that's usually what I aim for, especially in my female patients who have fatigue. It's been shown to be helpful to get their ferritin levels above 50. We don't want to overshoot because sometimes that can actually worsen a fungal overgrowth. So again, we want to kind of modulate where we're shooting with iron levels. And then risk factors, they're really quite similar to SIBO, a lot of them. And so we always want to make sure we're not having someone on acid suppressive therapy that they may not necessarily need to be on. So we want to check what the indication is for that if they're on a PPI or acid blocker. Opiates can contribute to predisposition to SIFO. Other risk factors would be things like motility disorders, antibiotic use. And then one that's different from SIBO is this whole hypersensitivity or allergic component. So I often will refer patients to a local allergist to have them evaluated for mold, pollen, grass, all of the allergy type of issues. And then we also use it there in addition to usual allergy treatment for that. We sometimes use a therapy called low dose immunotherapy if we find they're having this sort of allergic reaction to yeast as well. So that's that part of the pyramid. Did any other questions come through so far, Bridget, or should I keep going?
I have a couple questions.
Okay, go ahead. I know that was a lot.
I know the EMF. Well, I just wondered if you've done any research about specifically it sort of encouraging fungal or mold growth. I think there's some research out there that I haven't really followed up on. So do you tell me more about your understanding or your reasoning for why you do it.
Yeah, so the reason we do it is not necessarily based on research for SIFO, but just research from some of the building biologists that we use. They have some compelling information on the effects of Wi-Fi radiation and electromagnetic fields in general on our bodies. And so the Institute for Building Biology is a really good resource for that. But as far as specifically for SIFO, I don't have specific research on that, but Dr. Klinghardt, who a lot of people know, he has quoted research from some of the colleagues that he has where they exposed mold growing, I think on growth plates or in some other fashion, to Wi-Fi and away from Wi-Fi radiation. And it showed significant potentiation of growth when there was exposure to Wi-Fi. So it's something I should do additional research on, but we do it more for sort of general health effects that we've learned from our building biologists.
Okay, yeah, I need to look that up as well. My understanding is like it kind of creates a stress for the mold, and under stress they try to spread. So but yeah, I need to look into it more as well. And yeah, it's bad for the blood-brain barrier. I feel like if you have a sensitivity there, maybe from mold exposure, you could get really sensitive to EMF. And those easy things you explained to do are just that. They're pretty easy. So it's like It's a minimum, let's do those things. The low dose immunotherapy I hear about, I honestly don't really know much about what it is. If you could explain that more.
Yeah. So the teacher of low dose immunotherapy is Dr. Ty Vincent. He's a medical doctor that had an integrative medicine clinic for many years in Alaska and then Hawaii. And he built on a previous therapy called LDA, which has been done in England for many years. It was called enzyme potentiated desensitization over there. It was brought to the US by Dr. Butch Schrader. And that was primarily for food and environmental and chemical allergies. And it was a way to sort of induce immune tolerance to allergies that may have been harder to treat through standard allergy therapy. and it uses very dilute amounts of allergies. They've been diluted at least 6 to 8 fold most of the time. And what Dr. Vincent did is he built on that treatment for foods, environmental allergies, and chemicals, and broadened it to include things like yeast. And so he has basically created dilutions of these types of things, including food allergens, environmental allergens, chemicals, and yeasts that he teaches other doctors about as far as how to use. And the way we use the yeast LDI, I think of it sort of like nosotherapy or a bit of a spin on homeopathy. It's different, it's similar and different in different ways. So, you know, the yeast is diluted out very far into the teens. So it's been literally diluted, 14, 15 times or more. Beyond 12 times, there's really no antigen left in there. It's really an energetic homeopathic type frequency. And so it's a way to help reprogram the immune system to induce tolerance to these organisms that our body may have developed an intolerance to. And so some people, and Bridgit, you probably are aware of NAAT that some practitioners and acupuncturists use for allergy desensitization. And so I think of it sort of a different way to reprogram the body on that energetic level. If we've not had success just clearing the overgrowth through our standard treatments. Does that make sense?
Yeah, that's great. I actually was on his site once, now that you mention it, because somebody brought it up to me. It seemed like really expensive, but maybe as a practitioner, you're getting like...
Yeah, it's not that expensive. Once, like, it was expensive for me to invest in purchasing the therapies, but it's not that expensive to administer to patients because we use it sublingually. It's just a couple drops under the tongue about every 2 months. The tricky part is finding the right dose for that patient, which can take up to several months, I tell people. So once you find your dose, it's not very expensive, but there is a bit of investment like the first year while we're trying to find it because we need to give them many doses, but it's not too bad compared to standard allergy therapy, for example.
Perfect. Well, thank you.
Yeah. So what else, Bridgit? Any other questions, or I can talk about some of the other areas here?
Yeah, you can keep going. I'm curious about those motility agents. I think not as many people know about that as...
Okay, sounds good. And I'll just briefly talk about, that the antifungal herbs and medications that we use. Whether we use herbs or medications for SIFO, I really try to individualize it for the patient. I tend to prefer to use herbs just because I've used them for a long time. They're really safe, and I feel like treating the SIFO can be a several month process, if not longer. That being said, there are some very old, safe antifungal medications as well. The one we've used frequently is called nystatin, which is not systemically absorbed. So there's not really any systemic harm to using it. And then there's fluconazole, which is what was used in the few published trials on this. And that is a systemic antifungal. So you do have to monitor liver function tests and check for drug interactions and that type of a thing. I typically will start with herbs. And if I'm not sure that we're getting anywhere or there's been an unclear response, that's sometimes when I'll move to medications as a couple-week trial at least. And then we'll kind of just see what's working for the patient. I tend to not use the systemic antifungals for long-term, but nystatin I do use for 1 to 3 months initially if it's helping someone, and then we can keep using it periodically if we need to. The herbs, we again have a pretty high safety profile, so we can use that for a 1 to 3 month trial and then address as many of those other risk factors as we can. Questions about that at all?
Any like favorite herbs or formulations?
Yeah, I have a couple favorites. So Thorn SF722 is one that we've used for many decades that I use a lot. There's another one made by Beyond Balance called Mycoregen that I really like as well. There's other ones that I use a lot from a company called Supreme Nutrition Products, and I like them a lot as well. They're not specific for yeast or fungi, so the only challenge with using those is that we don't know exactly what we're treating, but they work great. So a couple of their products that I use a lot are called Golden Thread Supreme, which is a form of Coptis, Malia Supreme, which is a form of neem, Morinda Supreme, which is a form of noni, Olive Leaf Supreme, which is olive leaf extract. So those are the main 5, 6 that I use frequently.
Awesome. That's really helpful. Yeah. And if I didn't get all those written down, people can watching can like go back and
Yeah, that would be great.
Okay. Great.
Yeah, and then do you want to talk about dietary modification, Bridget?
Sure.
Or do you want me to go further above? Either way, you've probably had
No,
lots of
I
people
am curious about the
Okay.
dietary. Yeah.
Okay. So, I again try to individualize it, and I've changed a lot in the way I approach diet, where we try not to be overly restrictive just because of some of the psychological impacts that can have and socially and such. So we definitely recognize the importance of figuring out food sensitivities. But I try not to go to extreme dietary changes unless we're really getting stuck, and then we would use it for shorter periods of time. The main things I try to sort through with people is whether they have a gluten sensitivity. And so I'll often check antibodies for that through Quest or LabCorp. And if those are negative, we'll often use a lab called Cyrex array number 3, just to get a more full picture of all the gluten antibodies and if someone is reacting to that in any way, just because we know that gluten can have an inflammatory, it can cause inflammation in the immune system for weeks at a time if we're missing that. And then we try to figure out dairy as well, as most of you know that those are the 2 most common ones. So I sometimes will use IgG food sensitivity testing. We know it's not perfect, but it can be helpful as a guide. And then I recommend no refined sugars during our treatment, but fruit is allowed, carbohydrates are allowed as long as they're tolerated. We don't overly restrict those unless someone tells me that they have flaring of symptoms when they eat starch. Otherwise, we try to include safe starches as tolerated. And then I almost always have patients do something called a yeast mold elimination challenge. And this is a 5-day dietary elimination challenge where we remove yeast and mold related foods for about 5 days. And that includes things like, again, I have on my website kind of a resource guide for that under the resources section under digestive. And the foods we remove are not because they're unhealthy foods. It's because someone may have developed a sort of cross-reactivity to molds and yeasts if they have an overgrowth. So for 5 days, we're removing mold and yeast-related foods, which include yeast, dried fruit because it can have molds on it, vinegar, alcohol, sugar, and a whole list of other fermented vegetables, kombucha, things that can be cross-reactive. And again, there's a much more comprehensive list on the website. And then we have them, whichever of those foods they tend to eat regularly, like often it's vinegar or fermented vegetables, we'll have them add that back and monitor their symptoms for 1 to 3 days, just to see how their body is reacting to molds and yeasts and foods. If they react to those foods, we keep them out for the first couple of weeks of our protocol while we're treating the overgrowth, and then we challenge them again to see how they do. Often patients will regain tolerance to that once we've gotten the overgrowth down over a period of time. And then other things, we try to keep the refined sugars out more definitively. If they don't react to those molds and yeast and foods, they don't need to keep them out. Then we just keep the refined sugars and their own sensitivities out.
Okay.
So that's how we do diet. Any questions on that?
No, yeah, I think that's reasonable. I was just remembering a story. It's actually when I was in Portland at McMenamins at some group event, and this woman brought all her own food to the restaurant.
Yeah.
She had SIBO, and she was like a coach, and she was just like, well, this is how I manage it. I have all my own food all the time. And I was like, oh my God, this isn't really
Yeah, that can be super stressful. So that's what we try to find.
situation.
Yeah, we try to find kind of a middle ground, and so people can still enjoy and still improve. Yeah. So, and then next on here, so we know that motility disorders are a risk factor for SIFO, just like SIBO. There's no research that I found on using motility agents in SIFO. That being said, I think it makes sense to try them just because we know that can be a potential risk factor. And so there's a lot of things that can be used. There's natural motility agents, there's prescription motility agents. So the main prescription one we've used is procalipride, which is frequently used with SIBO. The main natural ones we've used are things like Motopro, ginger, motility activator, peppermint oil. So there's lots of different options here. I would say I don't use these routinely with patients, but if we find they're having frequent recurrences and we suspect that they're having a motility issue, those would be reasons where we'd consider adding in something as a trial to see if it will help prevent their symptoms from coming back over and over. And then as far as adjunct medications, we do sometimes use things like mast cell stabilizing medications or supplements, just because there is some research on SIFO triggering mast cell destabilization. And so the main ones I've used for that are some prescriptions called ketotifen and cromolyn. Some other ones are hydroxyzine is one that we've used frequently as well. And there's a whole host of other mast cell stabilizing medications that can be used. Those are some of the main ones. We even use routine over-the-counter antihistamines like Zyrtec, Allegra, Claritin, if we think histamine and mast cell are part of what's causing that person's symptoms. As far as natural agents for mast cell stabilization, we've used things like quercetin, vitamin C. Those are some of the main ones that I've used with patients, and a product called BCQ as well. So those are common ones for that. And then hidden risk factors as far as what do we think about if someone's just not responding to treatment, or if they're responding and then symptoms come back. So what I think about in these cases, sometimes you just have to treat for longer. And so I do usually treat initially for 1 to 3 months, but sometimes the body just needs a longer time getting used to the overgrowth being at a lower load in order for the immune system to sort of recover and reestablish tolerance. So one option is just treating for longer if it comes back frequently. Other things, definitely like we talked about, environmental mold exposure can make it difficult to overcome most health challenges. And so we definitely ask about that if it's something where the symptoms seem to keep coming back over and over again. Specifically, again, we talked a bit about mycotoxins, and either ingesting them or inhaling them can have a really detrimental effect on the GI tract. So it can cause motility disorders itself, and it can cause persistence of different intestinal infections. It can also cause intestinal permeability to worsen, and just general immune system dysfunction. So we're always screening for environmental exposure. And those are, and then the hypersensitivity issue. So if someone is potentially having like an allergic response to yeasts and molds, that's when I'll think about referring them to an allergist or talking to them about the LDI therapy.
Okay, interesting. Do you want me to, next slide?
Sure.
Okay. And I'm gonna have to get my cord.
Yeah,
so
no problem.
I might just let you run this thing for a minute here. I'll be right back.
That sounds good. So I know we talked about the dietary mold yeast elimination challenge. This is just sort of a pictorial overview of how I like to think about that. And I break it up into what we would do before we start antifungal treatment, during antifungal treatment, and after antifungal treatment. So before antifungals, again, just to kind of review, we try to identify what that person's individual sensitivities are. Often gluten and dairy are common ones. And we do that yeast challenge ahead of time. And the reason we do that is just so we know that when we start treatment, whether we want to keep out the yeast and mold related foods. And then during antifungal treatment, if they did have a reaction to the yeasts and mold related foods, we keep those out for the first couple weeks at least of our treatment program. We also keep out any foods that that person was sensitive to during the actual treatment, just to overall decrease the load on the immune system so we have the best chance at overcoming the overgrowth. And then after antifungals, that's when you can try to add back yeast and mold related foods, because again, once we get the overgrowth load down, some people will be able to tolerate those foods without a problem. So we just break it up into those 3 sections so we can kind of get some information before we start treatment and then re-challenge the foods after treatment.
I think you're finishing the slide, right?
Yes.
Perfect, sorry.
And then Bridgit, this is just a link to, through my website, a more in-depth version of describing that yeast mold elimination challenge from a wonderful sort of founding functional medicine doctor, Dr. Sydney Baker. I was able to get approval from him to post this booklet that he wrote on the website. because it's no longer in print. He wrote it in like the early 1980s. So it's a really neat little booklet. He was way ahead of the rest of medicine on treating this problem a couple decades ago, before we had a lot of published research on it.
Okay, and I can show that later when
Great.
after your slides.
So this is an overall overview of how I approach treatment with the actual medications or antifungal therapy in general. And so to start with, if we suspect SIFO and yeast overgrowth, I generally do a trial of yeast-specific or non-specific herbals with that list that we talked about. If they have improvement, we'll often continue for 1 to 3 months at least, and then kind of try to figure out any other risk factors during that time that we can work on while we're treating. If there's no improvement with the natural options, that's often when I'll try the pharmaceuticals, just because we know they're working more specifically on yeast for the most part. And when I do use pharmaceuticals, I typically use nystatin to start with because it's really safe, no systemic absorption really. So there's minimal risk of causing harm with it, outside of if someone has an actual allergy to it, or occasionally it can cause gastritis for someone. So I'll usually start with that and do a 1-month trial of that to see if it affects someone's symptoms at all. And then if that doesn't seem to do it, we'll sometimes do a 2-week trial of fluconazole, again, just to get more data on if this problem is part of what's causing someone's symptoms. And we're really looking for not only improvement in GI symptoms, but if they have any systemic improvement in things like fatigue, brain fog. I've had patients where their joint pains improve. Various different systemic symptoms can improve just because of sort of far-reaching effects of the reaction to the GI microbes, as well as some of the metabolites that yeast produces, like acetaldehyde.
Okay. Do you ever see like swollen lymph glands in the neck as a symptom?
You know, we see that with a lot of things, but I can't say I specifically notated it as in relation to intestinal overgrowth. Definitely in my patients who have a lot of allergic issues with environmental exposure, we see that with chronic sort of reactivation of viruses, and sometimes with tick-borne infections, we see that as well.
How interesting. I brought it up because when Microbiome Labs came out with a yeast product, I was taking it just sort of for fun, I guess,
Yeah.
as a trial. And I noticed that all really went down, and I was
Oh,
like,
great.
I thought that was like Epstein-Barr or something, but it seemed like it responded to a candida kind of treatment. So
That's great.
yeah, it's interesting.
Yeah, I've been wanting to try their product because it looks really good, but it seems like it's been on back order forever. So I haven't been able to get any for the clinic, but I've been hoping to try that product as well.
Yeah, it's pretty gentle compared to some, but it did seem to do something for me. So
Good.
Okay. Go.
Great. And then this is, I know we were focusing mostly on SIFO, but I know, Bridget, since you do a lot with mold, and I've done quite a bit with it as well, we wanted to touch on that at least. And I think we've got, let's see, we've got at least 5-6 minutes here. So this is an overview of how I approach environmental exposure or mold-related illness. And so I found just kind of trying to simplify it has been helpful for me to get an overall overview of how I like to approach it for myself and my patients. I'm not a huge lab testing person for mold-related illness. I'm not convinced that things like urine mycotoxin testing make a significant difference in how I treat patients clinically. Not that it's wrong to do it. It just hasn't given me the information I needed as far as, is this person having current exposure? So it can be helpful for other things, but the main thing I'm usually trying to figure out is whether someone has a current exposure as part of helping them to get better. Because if they have a current exposure, we're just going to be kind of spinning our wheels with everything else we're doing. So on the left here, you'll see eliminating the source of exposure. And the main thing I've learned with treating patients for environmental exposure over the last several years is that we really need an environmental professional on our team. I used to try to do ERMI testing and other testing with my patients, and it really confused things. And it's just not the same as someone going on site to do an evaluation. And so it would be kind of like ordering some labs on someone without ever talking to them or doing an exam, so that's how I think about it for the house. We really need someone on site to be doing a full exam of the house as well as part of what we're evaluating. So we work really closely with environmental professionals who will do that on-site work and do testing for our patients. And we always want to try to figure out if they have exposure at work, at home, in their car, anywhere else that they're spending a significant amount of time. And I know during COVID, that's people have had less exposures, but it could even be like the church they're going to once a week or different places like that they go to frequently outside of home. And then treating their personal belongings. I've had patients where they, when you have exposure, a lot of people have cognitive dysfunction and brain fog. And I've had patients that have moved and they were feeling a lot better. And then they brought all of their old stuff with them, particularly upholstered furniture and things like that. And they started to go downhill again. And they weren't able to make that connection until we talked that was part of what was making them sick again, because of some of the cognitive symptoms that exposure has on people. And it's just can be hard for processing and cognitive, figuring out things cognitively for yourself when you're having exposure. So our environmental professional helps with that, but I always do take a history of the house in general, just to get some clues about if I think there's exposure. And I think I have a checklist on my website as well of the questions I ask patients about that. Specifically, I frequently ask about basement, crawl space. Those are the most common sources of exposure we see for patients. And sometimes there's a really obvious exposure that they're having. And then for personal belongings, when they move, I tell everyone to, wash everything that's washable, include borax in that. And often that will be sufficient to remove some of the molds and mycotoxins, as long as the materials have not been directly damaged. Sometimes if it's still causing issues, we keep them in closed bins for a while and just wait for exposure later to see if they tolerate it. For upholstered furniture, it's tricky. Those often need to be disposed of, because even if they didn't have direct contamination, if someone had a forced air heating system in their house where there's a ducted system, we know the molds and mycotoxins are traveling from wherever there was exposure, like the basement or wherever else, to the rest of the house. So we try to determine that on an individual basis and with our environmental professional, but sometimes the upholstered furniture can't come to the new place. And then as far as treating the person, we talk about detoxification and treating the internal reservoir. And so detoxification, it's not too complicated if they don't have current exposure. We usually do treatment for at least 3 to 6 months, continuing after they move. And I try to keep that really basic too. We want to make sure they're hydrating, having daily bowel movements. I use a lot of food-based fibers like flax, chia seed, psyllium husk. We go through different things that they tolerate or don't tolerate. I do often use natural binders as well, like one product called Takasumi Supreme works really well. I use chlorella at times, just depending on the patient's constitution and what they tolerate. And we use that with food-based fibers to help with detox. And then we use basic things like vitamin C, magnesium, and B vitamins. And sometimes some additional liver, gallbladder detox support if needed. And then I have limbic system retraining on the bottom here, just because we know that environmental exposure can cause limbic system impairment. And basically what that means is that with various exposures, stress, chronic infections, our primitive area of our brain can go into overdrive, and it starts to think everything is dangerous. And so people start to react to food, all different sorts of foods, even healthy ones. They start to have allergies, sensitivities, all sorts of things that they weren't reacting to before. And so we use a program called Dynamic Neural Retraining System, or the Gupta program, that patients purchase on their own. We're not affiliated with them, but I often recommend they look into those programs. And they both have coaches that patients can work with. And that can be really helpful as they try to retrain their brain. It's not a mental health or psychological issue. It's really a structural change in the brain. So I try to be really clear with patients that it's not a mental health condition. So we often will include that. And then finally, on the right side here, treating the internal reservoir. I generally don't think of this as like an infection per se, but what happens is we all have colonization of microbes on our mucous membranes, and there can be either an overgrowth or the development of sort of an aberrant immune system response to fungi in the GI tract and in the sinuses, along with an overgrowth at times. And so we try to be comprehensive and treat the GI tract as well as the sinuses as part of our treatment. For the gut and systemic treatment, I often use the same herbals that we talked about with yeast overgrowth. The prescriptions don't work as well for the SIFO prescriptions like fluconazole and nystatin. are not as broad spectrum to cover things like other fungi and molds. So I do tend to stick with the more herbal options for this, for the GI tract. And then for the sinuses, there's many natural treatments we use. I also do use prescriptions for that area because it's very safe. So I'll often use compounded nasal sprays and nasal rinses that include itraconazole and EDTA or amphotericin and EDTA, just locally, not systemically, for the sinuses. I know we're about out of time, Bridget, but I think I covered everything I wanted to from that slide, but please feel free to ask any questions about any of that.
Oh, it's a really great slide. I think it can be hard for people to wrap their head around this project when they find out they have mold. So this really, I think, is really helpful. The limbic system retraining did get mentioned. So I think we'll use your talk here as also a bonus for our mold masterclass coming up. And we did have, you made Beth O'Hara, you know her from
I have heard of her.
Yeah, so she talked a little bit about these limbic system retraining programs, and we'll have Eva Detko on. I don't know if she'll cover that or not. So I know that some people may be less familiar with that. So I just wanted to give that a little extra mention that it's kind of just to sum it up again, it's sort of just this continuing overreaction even when the original source is gone, and it can be really annoying because you can't, you're smelling cleaning products and dust and I probably need some limbic system retraining, although I am treating myself with Claritin now, and that really helps. But I mean, you become overreactive. Your body went through a really serious threat, so I can be a really great kind of last step like you described.
Right. And sometimes it can be a really good first step too, if we're getting stuck and someone doesn't tolerate anything.
Great.
I have patients that can't tolerate any oral supplements. And so sometimes we'll actually start with limbic system retraining. And the last thing I'll say, Bridget, is just that a lot of us have had biases towards Western medicine or natural medicines. And so another really growth experience I've had is I really try to use whatever works for the patient. So we do use pharmaceuticals like Claritin and such. We use limbic system retraining. We do use herbs, and we try to combine all of it and not have like our own personal bias per se. We just want to find whatever will work for that person and give them some symptom relief as we work through the process.
Yeah, I just talked to a friend about that today. I'll just share this story because it's a good one. I'm sure you see, I was working with a couple with infertility, and they'd spent years not getting pregnant, but he didn't like to go to a doctor, so he never got checked. And turns out finally, I was like, he needs to get checked. So he had retrograde ejaculation. So he never had sperm contact the egg in all those years. So it's a great example of like, yeah, we have to kind of get over ourselves sometimes and see what works. So there was a question in the Q&A. Yeah. Could you mention more specific herbals for the gut and the system? Oh, I should. So let me just read it off. Can you mention specific gut/systemic RX herbals for mold? Thank you.
Yeah, they're really the same ones that I use for SIFO, the Thorn SF722, the Beyond Balance Myco-Region. Beyond Balance also makes a product called Pro Myco that's really helpful, especially if someone has current exposure and the other ones aren't tolerated. And then those Supreme Nutrition products like the Golden Thread Supreme, Olive Leaf Supreme, Malia Supreme, Morinda Supreme are my favorites for mold systemically and in the GI tract.
Okay, awesome, interesting. That Beth O'Hara talk, I learned something. She said that mycotoxins really respond to the glucuronidation pathway, so using herbs and substances for that pathway, which are some of the same ones for our viewers for liver and estrogen detox. So I hope people can catch that talk because that was new to me. That was really interesting. I wanted to show your website, so give me one sec.
Sure.
Is it your name?
It is. It's amikapadia.com.
Okay.
Let me know if you need help with the spelling.
I'm just losing my. There we go. Put these slides away. I feel like you should write a book on this. Are you writing a book on this?
So Bridget, I literally just, I told you I put that course together. It was a ton of work. So I admire all of you that do all of these summits. And I had no idea how much work it was going to be, but I just felt like I needed to consolidate the information from my last 20 years of researching like fungal related issues internally and externally. So I
That was
made
like,
myself put together a class.
okay, that was your brain dump.
That was my brain dump. And it literally, I tried to put everything I know about SIFO and mold in that class. And I should have a tab for courses. Okay, good. It came up. There's the one for practitioners includes, it's on SIFO and mold, and it's like a full day, 7-hour type of thing that's on video now on Teachable. If there are any naturopathic doctors in Oregon, I was able to get CE approval for that. For everyone else, it's for information. And so I tried to put, like I said, everything from all of my, back when we didn't have as much internet access, like I literally had all the books and printed materials from 20 years ago when I started looking into all of this. So it's all in there. And then the patient course, I wanted to have something for patients because often when we do these talks, as a medical doctor, I cannot legally work with patients in other states, but I wanted to figure out something to help patients in other states because they would often call the office and I did not have anything to offer them. So I also made myself create a patient course. So that's ready too. And I thought, Bridgit, like it was good I was doing this with you today. I thought I need to get this done before I talk to you.
Oh,
So I got it done. It's on
congratulations.
Teachable as well.
Well,
And
it's
that's,
really affordable. Yeah, and you
yeah.
still discount is still open, so that's great. Maybe I'll remind you before our masterclass goes live in case you want to give a different discount for that. But that's so
Yeah,
great.
we can definitely check in about that. I talk really fast, as you might have noticed. So the patient course is an hour and a half, but it might take like a couple hours. You can play it on a slower speed.
Okay.
But I wanted to give pretty much all of the same information to patients that I gave to doctors, minus a couple things that wouldn't be applicable to them.
Okay, perfect. Yeah, and I really encourage, I like your minimalist idea, but I also encourage like sort of like the pick your own path. And most of our clients, I'm sure yours are the same, are just pretty knowledgeable by now, and
Yes.
they're just trying to add in a few pieces to the puzzle. I want to show the resource about. Oh, look, I'm navigating just
Great.
fine.
Perfect. Yeah, no, that's
um,
great.
this was what you said the thing was with the.
Yes. So there's Dr. Sydney Baker's booklet, which is,
Okay.
I would recommend everyone to read. I don't have permission to redistribute that, but if you click on it, Bridgit, it will go to the PDF. And so I found that super helpful when I started learning about fungal related issues, again, externally and internally. It's from 1983
That's
or whenever it was
adorable. Oh
published,
my
but yeah,
gosh.
it's a wonderful, it's like one of the most informative booklets for anyone who wants to learn about these issues. So
Cool. Well, I want to maybe close with something I should have done. I was kind of distracted getting the slides, but you said, it's bloating. It's could be some other things too, maybe like if it's systemic joint pain. So maybe if you could just say one more
yeah.
time, like who should be considering this?
Okay, so I would say definitely if there's digestive issues like irritable bowel syndrome, reflux, eosinophilic esophagitis, there's been links to inflammatory bowel disease and excess candida colonization as well. So I probably missed some, but a lot of digestive issues. But in addition to that, again, people can have far-reaching effects, as your audience, I'm sure, knows, to microbes in the GI tract, even if they're not existing in those other parts of the body. Because of this gut connection to the skin, to the joints, to the brain. So anyone with sort of a recalcitrant case of something, it can be fatigue, it can be, I see a lot of cognitive dysfunction and brain fog. I do have a patient with rheumatoid arthritis who the only thing that has helped her joint pains is when we treated her for intestinal overgrowth. So through multiple mechanisms, yeast and fungi can affect different parts of the body. And so a lot of people these days are getting diagnosed with MCAS and histamine disorders. And I definitely treat people for that with meds and herbals, but we again want to figure out what is triggering the mast cell destabilization. And Dr. Theo Haridi's work has showed that fungi and yeast will cause mast cell degranulation. So there's far-reaching effects of overgrowth on the mucous membranes to multiple different body sites. So I would say I've had patients with psoriasis, particularly scalp psoriasis, skin disorders, eczema, I can't, I can't think of a body system, interstitial cystitis, endometriosis. It really can affect wide ranges of organ systems in the body.
Oh, okay. I'm really glad we went over that. Yeah, I think it can be hard to find like people, from my own experience, I told you that little story about Candida, but from my own experience, like you cannot have some of the traditional
Yes.
symptoms. You don't have to be having yeast infections. And what I found myself is like, I'm pretty fairly careful with my diet. I think there's some big triggers for me, like alcohol, I just stay away from. So it sort of like becomes kind of quiet. Like it's not, but it's not gone. So I always say
Yeah.
like, you can't just treat it with diet. So I think it's good you went over kind of
That's a
more
really
of the
good point,
process.
Bridget. Yeah, you definitely can't like quote unquote starve it out. I mean, dietary changes help, but in my pursuit of not having people do really involved diets forever, if it's not going away, definitely get evaluated by an allergist or an environmental medicine doctor who does low dose immunotherapy, because I find like food allergy or this yeast allergy can keep it going, because just allergic issues on the mucous membranes will just make you prone to overgrowth over and over again.
Wow. Okay, that's good to
So
know
that's a
too.
frequent one that's missed. And I for still forget sometimes. That's why I made this again. I needed these diagrams, and I have to tell my patients like, what are we missing? Because it's hard to keep track of all of it.
Yeah, so people can fly in to see you if they can't.
They can. And at
Okay.
some point, I tell people, if I don't actually send out any emails or anything, but if they want to sign up for my newsletter on my website, whenever the telemedicine laws change, which I'm sure they're going to in the next few years, I'll let everyone know if I can just do virtual, because it's a pain to fly to see someone. And I do think it's coming in the next couple of years, just because of with all the virtual medicine going on. And I'll let everyone know, and I don't email you with anything else extraneous. So
Okay. Okay. Except our mold summit, maybe.
except if they want to know. Yeah, I'll try to send out an annual thing about my class, but believe me, unfortunately, I don't have time to
I'm sure.
do
Yeah, no,
everything that
it's
you're
too
doing. So
hard.
thank you
Oh,
for
yeah.
what you're doing.
It's very difficult. Last thing I want to point out from that list was who I met you through, Siobhan Sarna. I think she really taught me that a lot of IBS is SIBO or SIFO. So we think, oh, well, it's like this parasite or gut infection or, foods,
Yes.
but you're not really thinking about the small bowel as being a cause. So if you do have that just chronic constipation, diarrhea, alternating, cramping, I think this is all really important to investigate. I would send people to her book as well, which is really an excellent short read.
That's great.
Yeah, so they
Yeah.
could take your course, they could pick up that book, and I do think it's like a underappreciated cause. I don't know, there's something not sexy
Yeah.
about it. It hasn't caught on.
I know. I think because we don't have the non-invasive test and there's not enough published data yet, but I think it's super common. And I'll say one more thing if we have a minute, Bridget, just
Sure.
because. So whenever I talk to patients with specifically irritable bowel syndrome or these sort of resistant GI and systemic conditions, it's almost never just SIBO or just SIFO or just parasites. I do a form of biofeedback based testing or kinesiology testing. I don't use it for diagnosis per se, but I tell patients based on my clinical experience and using that, everything in combination, it's almost always a combination of bacteria, yeast, and protozoa being out of balance and resulting food sensitivities, as well as the nervous system, like the limbic system. So it's almost always this conglomerate of all of those things together. And if we aren't comprehensive about it, we'll get kind of resistant symptoms. And so not to have it be overwhelming, because we often see improvement when we just address a couple of those because the treatments we use overlap. I think because I'm in Portland, where Dr. Seebecker is a friend of ours, and I think everyone knows about SIBO now. And so a lot of my patients have already been treated for SIBO. And so mostly what I find is the protozoa, yeast, food sensitivities remaining. I think SIBO is definitely part of it. Just a lot of people here have been treated for it already. So just sort of like keep that in mind. If you've been treating stuff for a long time, we do have solutions to those. And the LDI therapy is really good for the food sensitivity, yeast sensitivity part, if that's not getting better on its own, because some of us are just predisposed to allergies. And so we can treat the bugs over and over. And it's just like our mucous membranes are still inflamed. So, I've reframed kind of how I look at it, and we're not really going for perfection or necessarily complete resolution. Like that might not be possible for everyone, but we always want to try for as much improvement as we can get and just kind of reframe our expectations that it's going to take some time to get through all of those layers. And we'll keep going till someone is at the place where they feel comfortable, you know?
Okay. Okay. Awesome. Well, thank you so much. I can tell you really know your stuff on this, and I hope some people find it who this is like their big breakthrough. So,
Yeah, I hope it was helpful. And thanks for having me on, Bridget. And thanks for
very
everything you're
much
doing to educate
so.
everyone.
Yeah, thank you. And you guys, we actually have another talk tomorrow with Trina Felber about holistic dental care. That's like always a super popular
Oh, yeah.
topic. So come back tomorrow for that one. And I appreciate everyone who's on live. Thank you. See you guys
Thank you.
tomorrow.
Bye,
Bye.
Bridget.